Hello and welcome to another video on amputees, this time the prosthetic video analysis. What we want to do here is look at the 4 videos that are on Blackboard and then analyze them as we go along. So you'll need to stop the video and then watch it on Blackboard and then come back to the screencast. Hope that makes sense. So if we get into this, the aims of this are to introduce you guys to analysing gait analysis when you're working with amputee patients, and then that will help facilitate your understanding of the problems that we encounter in gait analysis. We want you to recognise the effects of things like contractures that we're always fighting. Fixed flexion contractures of the hip is the enemy here. Want to introduce you guys to some upper limb amputees, and then just having a look at some of the practical and some of the cosmetic issues around prosthetic limbs. So our objectives: we want to recognize gait abnormalities in the 4 examples that will be presented. We want to formulate a treatment plan of how to correct these abnormalities. Remember, some of them will be motor skills, some of them will be physical skills. Explain the rationale and the effect behind fixed flexion contractures or hip flexion problems with prosthetic rehab. Some of the difficulties that we have in function with the upper limb, that's on case study 4, and then appreciate the practical and the cosmetic issues which are important. So we're going to move on to video 1. Video 1 is a very tall female who's wearing a lovely dress, which is probably not appropriate for doing some rehabilitation because you can't see what's going on. So what we want to do is for you to have a watch of this video, and then you can clearly see kind of what this individual is doing. And when you want to analyze gait analysis, you're thinking lots of different things. I want you to think about head position, shoulder position, pelvic position, and then position of the foot, as well as any walking aids that they're using. So just pause the video now, watch it very quickly, and then come back to the screencast. So pause the video now. Okay, hopefully you've watched the video now, and we're going to go on to the answers. So you can see that the physio tells her off for leaning forward excessively and looking down at her feet, and the physio counters that by making her look in the mirror. That way she's got that visual feedback. That will also, she's quite a tall lady, so she might be leaning forwards anyway and looking down because most people are smaller than her, so we've got to think about that too. She's got a really good 4-point gait technique, but she is moving a bit slowly. She's got a very deliberate step through gait. So yeah, it's not bad, is it? If we could get her to speed up, that would be good. We're always looking for increased hip extension whenever we have that, slightly better confidence. You'll notice that when all the amputees turn, they tend to pivot on their sound limb and not the amputated side. But it's worth just bearing in mind that she's obviously quite an experienced amputee, and she's been walking for a while. She's a below knee amputee, so it's going to be much easier than an above knee, but that just gets you, that's a very good example of how to walk there. We won't come on to that too much. We'll move on to the next case study, which is video 2. Who's another below knee amputee. This time it's a male. What we need to do is watch the video of them walking and then see what problems you can see in their gait, why you think they're occurring, and then what ranges of movement at the hip and the knee are required for normal gait. So stop the video now. Okay, hopefully you've watched the video video 2 of the below knee amputee walking, and then these are the answers that we're doing there. So he's a lot faster than the female in case study 1. He's got a good step through technique, i.e., so what the foot is passing each other each time rather than stepping two. However, because he's moving so fast, he's got a lateral sway. He's moving excessively left and right, and that's very obvious. You can see that on the shoulders and the hips. Also, he's not really putting any weight down through the stick on the right. The whole point of 4-point gait is that you're using the sticks and the feet, and he's overstriding slightly with the right leg. So if we were to, this is a lot easier to correct, because in case study 1, she's not really doing anything apart from moving slowly. She's not really doing anything wrong. Whereas here we want to try and correct that lateral sway. So what you could do is when the patient is walking, you could literally stand by the side of them and block excessive lateral sway. That would be a way that I would do that. You could also work with a belt that you're pulling against the lateral sway or reducing the lateral sway. You want to correct the motor skills of overstriding. Overstriding on the side that's amputated is very, very common. So we want to make sure that your step length is equidistant, equal distance. That's going to be a real game changer for that individual. In terms of other things that we're looking at, it's really to do with the fact that on that amputated side we've got excessive amounts of flexion, and they will naturally sit down for longer periods, and as a consequence they will have increased amount of flexion. So it's all about hip extension. It's all about lying on your tummy, trying to get some stretching through that quad, through that hip flexor, and engage those glutes as much as we can, because obviously with the limb not being there, there's no weight to hold everything back, so the hip flexors tend to sit in that fixed flexion position, and after a while that can become a fixed flexion deformity. So our next video is video 3, and here we have above knee amputee. Above knee amputee is going to be very different in the way they walk in comparison to a below knee. What I want you to do is just analyze their gait, see what's happening, think about what treatment plans are important for gait, and then think about some of the functions of some of your muscles like the latissimus dorsi, and why they might come into more prevalence than our below knee amputees. So go and watch the video now. Okay, hopefully you've now seen the video, and we'll go on to the answers. Right, so obviously it's it's an above knee amputee on the right side. So they're using a 4-point gait system, i.e. they've got 2 sticks, and you can clearly see that they're circumducting the right leg, and they're also hip hitching. They've also got an excessive forward lean, and there's a pregnant pause on one side as they kind of transition, and they're using a step 2 gait rather than a step through. So here, because it's so difficult for them to get that proprioceptive feedback, because remember that the bottom of the stump now becomes the foot, and if that's the mid shaft of your femur, it's going to be much harder to kind of almost guess where the foot will be, because you get less feedback through what's going on. So it's a real skill of learning how to walk again, very genuinely. So here we could correct the circumduction by doing some weight shifting exercises, by strengthening the glutes and giving them some better endurance. So glute med and min in particular, but also glute max. We want to be stretching those hip flexors, trying to work on any tight tissue that would naturally accumulate there, and that's going to hopefully change the circumduction and the hip hitching. Now there's a big thing about circumduction, it doesn't look right, but it actually might be more energy efficient and easier for that individual. So if they can ambulate by circumducting, let them do it, and then just tidy it up as we go. They don't have to walk perfectly, but they will benefit from just mobilizing in the first place. Stepping 2 rather than stepping through, that requires a greater level of confidence from the individual. And that's why you need to use the sticks more, so they can be in a more upright position, correcting that forward lean, having their center of mass over their base of support. So video 4 now. This is our upper limb amputee patient. So what I want you to do is watch the video, and then we're going to thinking about what are the common causes of upper limb amputation, why, what's the difference between upper limb and lower limb in terms of prosthetic. We've also got to think about, the function of an upper limb prosthesis as opposed to a lower limb prosthesis. And we look at the classic split hook and how that affects the wrist and the hand. So go and watch that video now. Okay, hopefully you've paused this screencast and watched that video, and we can go on to the answers. So the most common cause is accidents for the upper limb. Industrial accidents, lots of other things like that, and then it's going to be followed by infections or burns, and then unfortunately some sort of tumours, so referring to things that have to be removed like cancer. This lady is 4 years post amputation, so she's well out of the grief cycle. She's come to terms, she's accepted what's going on. She can don and doff her prosthetic very impressively, and she's very highly skilled at what she's doing. She was originally right-handed, which is going to affect her massively. She now has to do everything with her left hand. And the high levels of motor skill that you require for an upper limb prosthesis are unbelievable, particularly with the new intelligent limbs, the new eye limbs that we have now, which work from biosensors. There's a real change into what's going on in the prosthetics market for the upper limb. So she's using an iso-ROS pin that kind of clicks in to the more comfortable arm, as she calls it. And that's the arm she uses more often. That clicking in pin system is important, but she also shows you the split hook system. The split hook system is a very old system, but it works really well and gives the patient a bit of freedom by using the proprioception of the scapula, and that is a really good way of using that really functional split hook. There's 12 various positions that you can put the split hook on, so it's highly functional, and it doesn't require a huge amount of computing because it's all mechanical. So it's a very good bit of kit to give to patients in the developing world, for instance, rather than giving them a computer that will require significant maintenance. So with the upper limb, we looked at the cosmetic limb. She says that it just fills a sleeve and makes her feel more normal. So we've got to think about the cosmetic and the functional side of things as well. We all like to look our best, and if you're an amputee, why don't you want to look what is called normal? There's a big discussion about normalization, and the amputees should just be proud of what's going on. That's who they are, and they should be showing that off, but that is up to the individual. And the upper limb, is entirely different. The psychology of it is entirely different because we're dealing with the hands, and the hands are highly functional. So if we look at the lower limb is all about gait, whereas the upper limb is all about function. Dressing, washing and dressing, activities of daily living. It's going to take a long while to do it. The good news is that the heart and lungs should not be affected, because you can still do activities with the lower limb, but the skills required and the patience required to use things like the split hook and the upper limb prosthesis, they are pretty significant. So there's going to be a lot of learning that they do with the OT, the prosthetist and the physio, all working as part of the MDT. So there you have it, a whistle-stop tour through 4 different amputee patients. I hope you can now spot what's going on and what you need to be aware of and how your clinical reasoning will be affected.